we are really excited to have everyone today. For those of you who have joined, you may want to be listening to the original audio, which will be in English for all of the speakers, but you may want to listen to audio in French or in Spanish. Donc, pour vous qui voulez écouter en français, assurez-vous que c'est mieux le français que vous pouvez écouter que ce que je parle maintenant. Donc, vous pouvez vous connecter en faisant clic sur le petit icône de globe ou monde qui a disparu de l'image de l'écran, mais qui doit être dans le boîte à outils, dans la partie inférieure de vos écrans. Christy, over to you for the Spanish.
Hola, muchas gracias, Angela. So, if you would like to listen in Spanish, si usted quiere escuchar este evento en español, las instrucciones son iguales que las instrucciones en francés. Ahora voy a cambiar la pantalla para que puedan ver las instrucciones en español, pero lo único que uno tiene que hacer es hacer clic a la imagen que parece ser del mundo, que está en la parte debajo de la pantalla. Entonces hay una imagen que parece ser del mundo aquí, y si uno le hace clic, aparecen opciones de oír en inglés, en español o en francés. Entonces uno solo le hace clic al idioma en que quiere escuchar el evento y pues ya. Y también tenemos un documento que explica este mismo proceso y lo vamos a agregar al chat. Okay, back to our speakers.
Thanks a lot, Christy. And just as a notification to everyone, one last point is that we are recording today's webinar. David, over to you.
Thank you, Angela. Welcome, everyone. I'm glad you could join us today for the launch of the Global Report for the Health of Persons with Intellectual and Developmental Disabilities. The report is called Focusing on the Invisible. This is because persons with IDD, most times our disability isn't clear to persons when they just meet us. So it's assumed that we don't have a disability or that we are just being mischievous. When it comes to getting treatment, we are misdiagnosed or not taken seriously. So rather than getting treatments that make us better, we get worse, or we are neglected or abused because of misunderstanding. I am David Duncan, the chairman of the Global Athlete Leadership Council and the health liaison between the Special Olympics International Health Team and the Global Athlete Leadership Council, the GALC, the GALC. I have also been part of the editorial review group for this report. I've also been part of the editorial review group for this report, so I know there are many people involved in working on this report. The list is too long for me to go through now, but the acknowledgement section of the report is up on the screen. It includes my fellow members of the editorial review group, the research, data, and advocacy consultants who have worked closely with Special Olympics on this, and the Special Olympics programs at the heart of it. They have done so much, including making sure that Special Olympics athletes who are people with IDD shape the Rosemary Collaboratory initiative, which includes this global report at the local level. I'll be your host today as we run through our program. I hope this meeting will be educational and enlightening to you. Thank you all for being here.
Thank you, David, and hi, everyone. My name is Angela Jenkins, and I've overseen the development of this report from the Special Olympics International staff side, as well as being a part of a large and global team, as David pointed out. Most of them are acknowledged in the report, except our fellow staff members. So those of you who have worked on the report, Hamza, Faith, and too many others to list here. Thank you, and your work is also seen. Our colleague Olivia has already dropped into the chat the link to the English version of the report, which is what we're launching today. And the translated versions in Arabic, French, and Spanish will be coming in a few short weeks. Thank you for your understanding, and back to you, David.
Thank you for that, Angela. Special Olympics is a sporting organization for persons with intellectual and developmental disabilities, where they can participate in sports, sharing of gifts, year-round training, and also in leadership and developmental skills. This allows them not just to participate in sports, but to learn to coexist with persons with and without intellectual disabilities in meaningful and productive ways. For nearly 30 years, Special Olympics has been increasing the work we do to improve health outcomes for Special Olympic athletes. The report is part of an initiative called Rosemary Collaboratory, which is an expanded effort by Special Olympics to tackle, promote health equity for all people with IDD. Special Olympics work in health would simply not be possible without our partners, the Golisano Foundation, and in the United States, the Centers for Disease Control and Prevention. The Golisano Foundation is a driving force here and have not only supported our vision of the report, but also provided the means to help make it reality. We are lucky to hear from the Foundation's Executive Director, Erica Dayton, who joins us today to share a few words.
Thank you, David. Hello, everyone. It's an honor to join you here today. The Golisano Foundation, our mission is to improve the lives of people with intellectual and developmental disabilities. We know that for too long, people with IDD have been pushed aside in healthcare, struggling to get even the basic services provided to them. People with intellectual and developmental disabilities are often overlooked, and their specific needs are not included when health systems are designed. This leads to poorer health, shorter lives, and unnecessary suffering. We believe that every single person deserves dignity, respect, and good health. That is why today's report is so important. Reports like this one help us put a flag in the ground. They give us proof and data that we can use to say, this is where we are today, and this is what needs to change. Without doing this, people with IDD will remain left out. But with this evidence, we can show the world that progress is possible and measurable. More than that, this report should be seen as a spark, a starting point for faster action. It is not enough for people with IDD to be counted in health data. They must also be listened to, included, and cared for in ways that honor their humanity. They should not be seen as patients, but as individuals with hopes, talents, and rights. At the Golisano Foundation, we know that change is possible. With strong partnerships, clear evidence, and a shared commitment, we can build health systems that recognize the value of every life. We are working to create a world where people with IDD are visible, included, and treated with dignity. Thank you to Special Olympics for leading this important effort, and to everyone here today who is helping to make health equity a reality. Now, it's my pleasure to turn it back to David Duncan, Global Athlete Leader. Thank you.
Thank you, Ms. Norton. Special Olympics has identified or realized that people with IDD don't usually get the correct health treatment. So the editorial review group was started to do a report on barriers and solutions to the problem. I have been involved in this report for over a year as part of the editorial review group, but the work started way before the editorial review group came together. Dr. Dimitri Christakis, Special Olympics Chief Health Officer, will share a bit about the entire process.
Thanks, David. The work of Special Olympics is most successful and is only sustainable when governments and health systems are involved. We started this project in 11 sites where Special Olympics health programming is very established. The truth is, in a perfect world, Special Olympics health programming would be obsolete. But to date, in spite of all our ongoing efforts, athletes keep coming for screenings because health systems simply aren't meeting their needs in one way or another. To try and understand the barriers to achieving health equity, the Rosemary Collaboratory teams did assessments of their health systems. Every site used the same tool, which included nearly 60 indicators assessing the structures, processes, and outcomes of their health systems. Notably, there was a universal paucity of outcome data for people with IDD. We collected lots of interesting information about policy frameworks and engaged a range of stakeholders, way more than I can detail here, but I do encourage you to read the full report. I want to show a slide here of some of the work in progress. You can see the left-hand image up there is from Nigeria. It's from a workshop that convened 26 stakeholders from across the country to validate assessment findings. In addition to the assessment tool, a facility accessibility assessment that was developed and implemented together with people with IDD was also deployed. The top right image shows one of 2 patient and public involvement in research events that the Rosemary Collaboratory Ireland team held to ensure that the voices of people with IDD were part of the process. At the first meeting, which isn't the one pictured here, attendees engaged in a collective intelligence activity to provide feedback on the assessment tool. The activity involved reviewing and commenting on the relevance of indicators, talking about indicators people felt were missing, and brainstorming potential sources of data and relevant stakeholders. At the meeting pictured, which included 7 people with IDD and 3 parents, the team sought the perspective of the participants on the inclusiveness of Ireland's health system to complement the data gathered through the assessment tool. The conversations focused on people in healthcare and places of healthcare. At the end of the meeting, participants helped prioritize recommendations for system change, as the point of the assessments was to shape subsequent advocacy. The bottom image is from Paraguay at Special Olympics Latin American Regional Games in October of 2024. Special Olympics Paraguay hosted a stand that highlighted key findings from the assessment. This board asked, what would you do to improve the health system for persons with disabilities? And includes answers like, be empathetic, less blah blah and more action, more information, train health professionals and include the opinion of people with disabilities in their treatment. In addition, the Rosemary Collaboratory initiative included interviews and focus group discussions with 77 clinicians in 7 sites, as well as quantitative analysis of survey responses of approximately 300 health workers from over 40 countries. Finally, over 700 people with IDD from almost 50 countries responded to a universally designed survey that was co-developed alongside 3 individuals with IDD from the US, the UK, and Zimbabwe. Those individuals work as consultants for SOI. All of this is to illustrate how the teams went beyond the assessment tool itself to provide a more textured and nuanced look from the 11 Rosemary Collaboratory sites. This mixed method approach better identifies what the key drivers for change need to be. And now I have the pleasure of introducing one of those researchers involved in the project, Professor Diket Singh Ned, Associate Professor at Stellenbosch University. Professor, tell us a bit about your work as part of the Rosemary Collaboratory South Africa.
Thank you so much, Dimitri, for that lovely introduction and the broad overview of the report. Colleagues, thank you so much for the invitation and the opportunity to share some of the highlights as we collected data in South Africa. So our approach to collecting or gathering some of the data for the report being launched today started off with us thinking very creatively about the setting. We all know that South Africa is such a diverse country and we have about 9 provinces in the country. So we had to purposefully collect data from a good representative of the country. In so doing, we then selected at least 5 of the provinces in South Africa to try and get an accurate representation of the whole country. These provinces were selected based on a combination of which ones are low-resourced and high-resourced provinces, which one are more urbanized or have more rural context, because it was important for us to ensure that all the different contexts within the country are represented in the data that we were collecting. We therefore used a combination of mixed methods, which basically integrated both quantitative and qualitative methodologies and methods. And we followed the Missing Billion Initiative Health System Level Assessment Tool, which was adapted specifically for this initiative, focusing on people with IDD. So information sources then that we used in South Africa included looking at government policy documents, looking at government reports. We looked at scientific publications, including grey literature as well, such as non-governmental organizations' reports, through conducting a scoping review of what evidence is already out there in South Africa with regards to health access for people with intellectual and developmental disabilities. We also looked at publicly available population data sets to look at broadly what data is there for populations in the country. Other information was also obtained from approximately 100 stakeholders, and this included 10 key informants who are health authorities, at both national and provincial levels of government. We included about 10 organizations of people with disabilities. We interviewed about 10 clinicians. We interviewed 30 family members of people with intellectual and developmental disabilities, as well as about 30 people with intellectual and developmental disabilities. And all of these stakeholders shared information through focus group discussions and individual interviews across the different provinces. The interviews were primarily focused on experiences of accessing healthcare services in South Africa. And we learned that most people with intellectual and developmental disabilities were able to access health services in South Africa, but those in the rural and semi-rural areas mentioned transport costs as a huge barrier to accessing health services. Some even shared experiences of translation, access to information, for instance. Interestingly, the majority of the interviewees with IDD did not understand the nature of their disability, but rather their understanding of their disability was based on their inability to attend a mainstream school. It is then important to note that this process in itself was not without challenges. So in South Africa specifically, one of the challenges that we faced included issues of what data is actually available or not in the country. When we accessed data from the national population-based data sets, such as our census data from Statistics South Africa, the South African National Health and Nutrition Examination Survey, as well as the Demographic and Health Survey, our findings revealed that some form of disability data representation is considered nationally in these identified data sets. And the data collection methods used were actually using validated and internationally recognized tools, such as the Washington Group short set of questions. But these questions actually do not accurately measure IDD. In fact, they are not built in a way that allows one to identify who are the people with IDD in this population. As such, none of the data sets then were able to provide specific IDD disaggregation data. This lack of disaggregation is well documented in literature and was repeatedly cited as a challenge by key informants who participated in the study. It is also worth noting that the lack of disaggregation also limits the possibilities of effective and comprehensive policy planning that would lead to enhanced services for people with IDD in the country. So this challenge then really pushed us to think innovatively about what could be possible to address some of this gap. And so what we did in South Africa is that using the available data sets, we engaged our biostatistics clinic in the Faculty of Medicine and Health Sciences at Stellenbosch University, where I'm based, to create and use a new composite indicator that could potentially assist us in saying these are people with IDD in the national data sets that we have. So for example, for each data set, we used a combination of the already existing Washington group set of questions variables to create a new variable, which we labeled possible IDD. So for example, we determined that all people who reported a lot of difficulty or those who reported cannot do at all for both communication as well as remembering or concentrating questions, all of which are actually typical domains of functional difficulty for people with IDD, would most likely have some form of IDD. And so we combined those people who responded with those two responses, that is either a lot of difficulty or cannot do at all. We then also introduced an age cutoff of 55 years and younger to try and minimize the possibilities of identifying people with dementia related to aging population in the data sets. This newly created then variable then allowed us to run it through the data set and do an initial analysis of some of the trends of this possible IDD population across the different health status data that we had. However, it must be noted that this variable is very broadly defined and remains untested against any gold standard. Therefore, we fully acknowledged in our data collection that this may be an imperfect measure, and so all calculations should be interpreted with caution, as it may exclude a number of people with IDD, especially those with mild IDD, who did not fit the cut-off criteria that we applied. What we are doing also going further then is to propose that in addition to what we've trialed out, governments could also then consider including an additional question that will be about age of onset. So if a person has answered a lot of difficulty in one functional indicator, they would then be asked when the onset was of this difficulty. What is then the key takeaway message in this process? For us, one key learning that I will always take away from this process, and one which I hope that you all take away from reading the report that is being launched today, is that we need to consider the heterogeneity of disability and even the heterogeneity of IDD if we are to make our health systems more inclusive and responsive to this population. I have been steeped in disability-related research for over 10 years, but applying this IDD lens helped me to better understand the unique challenges, nuances, and potential solutions that the report highlights. And while these challenges may be unique to those with IDD, the solutions stand to benefit other population groups who too face barriers when interfacing with our health system. Thank you so much for listening, and back to you, David.
Thank you, Professor, for that. Dr. Marcus Casartelli is Director of the National Directorate of Neonatal Screening at the Ministry of Health of Paraguay, joining us in representation of Minister of Health, Baron.
Thank you very much, David. I had a presentation, but it's not necessary. You had, thank you. Well, the next, please. Well, in Paraguay, we had a lot of problems to provide the service for the people with intellectual disability, and especially include physical or some, especially in the health system and in the school too. Right? But the Paraguayan government's commitment to the inclusion of people with disability, and it's this not new. In the last years, we had a set up all of the international law and orders to try to give to our people the attention, but it was difficult because the implementation for different things. The next, please. Mhm. If you see, we had initiative of collaborations with the Olympics and with the Special Olympics. And this is important because for me in particular, this is visually say the persons uh, with with intellectual disabilities in Paraguay. There we had different problems in the past. The people, well, as the other places of the world, the people are saying about their sons or they familiars with intellectual disability, and this is changing in the last 10 years, and right now we had a movement of the peoples that fight with inclusion and attention in the health system, and this is very important. And the Special Olympics give us a place to exchange opinions and try to improve the health care for these people. The next, please. The other, yes. In Paraguay, we don't have a data to visualize the full dimension of the health problem of the people with intellectual disabilities. And I know it as a physician, as a neuropediatrician, and work in the field, that this is a big gap between the general population and the person with disabilities, intellectual disabilities. Um, in the health system, we had a big problem. We had fragmentation of the healthcare. We had different systems that not communicate between, and that's make that the effort that every system do to get healthcare for these people um, don't look at well or don't is enough for these people. Right? The other thing, there is a lack of awareness of the needs of these people. And it's not only in the healthcare system, it's always about the population in general. Right? And another problem that we had is that the local institution of the local governance um, don't makes any effort to, well, there are places that make, but usually they don't make effort to give attention to the local population. And it is a problem because you know that the difficulties to the access is a very important problem for the people with intellectual disability and other health problems. And the next, please. um, but in the health system, we had a guidelines to the respectful and inclusive treatment. And, and I think it needs to be socialized with the healthcare providers. And and these guidelines will could give us a better skills to treat these people, but it needs to socialize for all the healthcare systems. And this is like the importance of this guideline is that all the systems need to apply it because it's a resolution of the Ministry of Health, but we need to socialize with them and will be very important for us. The next, please. regardless, we are very committed to change these things. We open to the collaboration. You know it that the people, well, the people who work here and who knows Paraguay know that we had an equal legal framework. We need to apply this legal framework, not to be a dead letter, and it's very important to work in it. And we demonstrate our commitment through the collaboration with the Rosemary initiative in Paraguay. I think it will be very important and demonstrate that the government of Paraguay is committing to improve the attention for the people with intellectual disability and other disabilities. The next, please. Well, in conclusion, the collaboration that we had with the Special Olympics and the it will be very important for us. We want to continue this collaboration, but we need to improve our effort to introduce to the healthcare providers the motivation to and skills to the better attention for our people with disabilities. And thank you for this space, David. I give you the word. Thank you very much.
Thank you, Dr. Casartelli. I am excited to hear about the work of the Ministry of Health of Paraguay is already taking on related to health worker training. This is one of the 4 sections of the report. To develop the report, the editorial review group for this report reviewed all of the information Dimitri and Professor Ned spoke about. We identified key properties based on the data, which includes relating with a wide range of persons with IDD. We also spoke with other persons with IDD to create recommendations. What we did is an example of what we want to see governments do in health policy making. The governance, leadership, and engagement section of the report talks much more about that. Person-centered care includes many things, some outside of the health system. Supported decision-making is important as persons with IDD sometimes need help from others without IDD to help to make wise decisions. While this is helpful, it is also needed that persons who are offering the support are knowledgeable and caring enough to be a good helper to the person with IDD and not hindering them in any way. To get health services, we need to go to health services. What I've seen happen in Jamaica is that people with IDD can get an ID card to get reduced fare on public transportation. Some people don't take advantage of it, but others who do sometimes find themselves having to pay full fare anyway because of the invisibility of their disability. Plus, the bus system isn't always reliable, so people with IDD may take taxis, which can be dangerous and expensive. Jamaica isn't even part of the report, but these issues are global. Communication is a definite issue for person-centered care, but it's also very related to the health workforce. Most of the healthcare workforce isn't taught to work with people with IDD and how to speak with people with IDD to make us feel more comfortable. You would think that a common doctor would have a basic understanding, but most of the time that is not the case. Most people with IDD prefer to communicate in simple language, and some tend to go slow. Some stutter and when they speak. Some people without IDD find this annoying, and they don't take the time to our patients to listen to the person with IDD because they might take a while to get to the point. They don't see the person as being good at communicating. And there are also persons with IDD who do communicate well and clearly, but because it's known the person has IDD, the stigma is there. So persons may not really listen. which makes a person with IDD feel low and less than a person because their views are not being heard. And from my personal experience, I know that going to the doctor isn't something I look forward to, even though I know the importance of health. Special Olympics healthy athlete screenings help, but it's not enough. It's not frequent enough. It's only reaching a small percentage of the population with IDD around the world. And it's a health check, but doesn't solve all of our problems. Getting follow-up care is hard and frustrating because you go from this caring environment to one that's very different. But it has been useful for getting data. Like I said at the beginning, people with IDD often have invisible disabilities or experiences or experiences are not usually very visible. No, our challenges are not usually very visible, and this can be a definite problem. However, people say that what gets counted is what counts. To me, it's clear that one of the reasons we don't count is because we are not counted, or we are not understood, or we are not taken seriously because misunderstanding and lack of knowledge. Some governments may not take action on the things I and other people with IDD care most about if they don't have all of the numbers. We should not use bad data as an excuse to not act, but governments should work to make data better along with other things we talked about. We have been watching the Q&A box. Now I'm going to open to a brief discussion. To my fellow panelists, what is something you've learned through this process that has surprised you?
You know, I wasn't actively involved in collecting the data. I can't talk about the process, but I can talk about the results. And I wish I could say I was surprised by how much work there needs to be done, but I'm very pleased by all of the enthusiasm, all of the energy, all of the very important insights that were gleaned. In particular, because of the mixed methodology that the teams deployed, it was clear in reading the qualitative assessments, the input that people with IDD and their parents provided, that those kinds of insights are what are really going to be essential to complement the metric data that we got.
Dr. Casartelli, is there anything that you would like to share as well?
Oh, yes. I am very agree with David. It's difficult for the people with intellectual disability the access to the health, and the transportation is a very big problem here in Paraguay too. And because that I I think that the involvement of the local governments is very important to the access of the help to this intellectual disability, the people with intellectual disability and other disabilities too. And I think is one of the things that uh, we had to put in one of the first steps to work. But there's a lot of things to do. There's a lot of work to do with the health providers. There's a lot that helps to a lot of work to do because in Paraguay especially they and they said that they don't know it about disability and then send to others to the specialists. And for me this kind of problem is a problem of the health system, and it's not only for the specialists. As me as a specialist I talk it, and there's a lot of there we want to we need to communicate to the or to try to improve these skills and in the first attention we call here primary attention, and we had about more than 1,000 centers around the country. But when a people with disability come to them, they say, I don't know about that, and then you need to go to the specialist. And for me, it's not correct. But we still a lot of work to do, and I think with the help of the Olympics, Special Olympics, is a space that the people want to go. Is a space that makes that improve the skills of these people, and just to make a little experience, personal experience. Last week, a patient came to my private consultation, and she said to me that it's my fault that her daughter sleep late because I sent them to the Special Olympics, and she only wants to go to the training, and she feels if it feels great there. And well, I asked them to talk with your trainer, please, to for a sleep soon. But the people feels that this is a place that can be free and be engage all of the potential. Thank you.
Thank you. I can share my lessons. I think for me, it was very surprising to see how much willingness service providers were willing to go in terms of addressing some of the barriers or even ensuring good access to healthcare for people with IDD. But because of some systemic and structural barriers, they did not always have the resources and the know-how of how to do that. And so it's very important. I think it highlights the importance of this work that is happening and how important it is to actually address some of the systemic related barriers, as well as strengthen health systems to ensure that they are responsive to the needs of people with intellectual and developmental disabilities. It was also very interesting for us to be working directly with athletes. And I think this on its own is a very good approach in terms of challenging some of the assumptions and stereotypes that people have about people with IDD. And so it was a very empowering process to witness as we were working with directly with athletes, as well as other organizations that work with people with intellectual and developmental disabilities. Thank you.
David, we've been watching the Q&A box, so I'm just going to come in with a few that have come in through there. So Prof. Ned, the first question is for you. If you are able to share experiences that you had with remote health workers and what their needs were to better serve the IDD community. And even though that question was directed to you, I am sure that everyone, including David, has strong thoughts about health worker training. So we'll start with Prof, and then others feel free to chime in.
Thank you so much. From our side, I think mainly the issue was being short-staffed and having lots of work to do, or having to see quite a lot of patients in a healthcare center in a day. And so quite a lot of the clinicians that we spoke to spoke a lot about how they hardly have time to spend with people with IDD in consultation rooms and take the time to understand their needs so that they can respond effectively to their needs as expressed by people with IDD, because they often work in circumstances that are overcrowded. They have a long queue of people outside waiting, so they have to be very quick. They also shared issues related to limited training, and especially with regards to understanding IDD understanding people with IDD and understanding their needs. They shared quite a lot of discomfort, that they are not comfortable working with people with IDD. So they would appreciate quite a lot of training to just generally understand intellectual disability and developmental disabilities, as well as understand how to respond to specific needs in their areas. Lastly, the one thing that I also spoke to is issues related to transport. Most of the patients that they see in rural contexts, they live far away from the clinics or even hospitals. And so the time it takes for them to get to their appointments, or even the added costs that they incur to get to these hospitals, is quite burdening to some people with IDD. And so they were not always sure how to navigate some of those challenges that would be expressed daily by people with IDD when they are working with them. And so it does impact on issues related to how do healthcare workers actually work together to ensure that they streamline if a person with IDD has an appointment with a doctor and appointment with other healthcare practitioners like your occupational therapist or a physio or an optometrist. How does one actually streamline to make this appointment on one day to avoid the back and forth to the hospital, considering these transport barriers and the long distances that they have to often travel to get to the healthcare center. So those were some of the issues that were shared. Of course, this is also combined with issues related to the health facilities themselves in terms of how inaccessible they can be, especially in rural contexts. The things that one would take for granted as having information that's accessible and communicated in accessible ways in some of these health facilities, that was not always there, and they were not sure how to navigate some of those issues and what policy actually says about those issues. Thank you.
Oh, okay, I can answer that question as well. And what I've noticed in rural areas, there's usually not many persons who are trained, specifically to work with persons with IDD. So, and the facilities that offer the treatment are usually few and far between. So persons have to travel great distances to get there, sometimes under bad road conditions and transportation issues. When they do get there, there's a long line, and it's usually a clinic or a hospital where it's not, you'll probably have like 1 or 2 persons who specifically deal with IDD. So the waiting list is long because you also have other persons going there for other treatments that are not related to IDD. So the patient gets there having traveled a great distance, usually frustrated. The parents and guardians don't understand what the person with IDD is going through. So sometimes there is physical and emotional abuse that the person is going through. When they get there, they have to wait a long time to get the treatment. So it can be a very frustrating exercise. So I strongly believe that more training is needed for the clinicians. So most of the time, most of the clinicians who do get trained are persons who are related to persons with IDD, or they live in a community or in a space where they see a person with IDD. So the general training of doctors is not specifically for persons with IDD. So it can be very frustrating. I think that process can be a lot smoother if you have more persons. As Professor Ned said, because of the short staff of persons with clinicians, this creates a backlog and can be very frustrating. And sometimes the person with IDD don't get the treatment.
Thank you so much, David. And we are up against the clock here in the last 6 minutes. So I'm going to ask you to move us along from the Q&A. We are answering as many questions in the Q&A box as we can. I had seen some hands up, and since we have to move on, feel free to drop them in there. And David, go ahead and take us to the last segment. Thanks.
Will do, Angela. Okay, thank you for your questions, everyone. All right, I would definitely encourage everyone to take up the report. It is good, and it's good that it's being launched. It's, of course, a stepping stone, but it's an important stepping stone. And it's important to get feedback as it evolves over the years.
I'd like to thank all of our speakers, Professor Ned, Dr. Casartelli, Ms. Erica Dayton. I want to thank all of you for being here and sharing in this important launch. And if you have follow-up questions, please email us at inclusivehealth@specialolympics.com. Download and share the report. And as our constituent or one of our constituents from Paraguay said, we need less blah blah and more action. So please join us. Thanks, everyone, for joining, and I leave you with these important messages related to focusing on the invisible. These are highlighted in the report. Please do download and read the report and share it, and join us in this incredibly important work to achieve long overdue health equity for people with IDD in the countries we're focused on and around the world. Thank you very much. Take care.
Thanks, everyone.
Thank you.
Bye.
Thanks, everyone.
Thank you, everyone.